There's a real intersection between the research that's happening and changing patients' lives.
If I had what I have, maybe 5 or 10 years ago, I wouldn't be here talking to you for sure.
Hope is what we do. Hope is what research is. Hope is ultimately what science is. The idea that we can control our fates, that the patient and myself, and under one umbrella, working together, can actually bring something new into existence that will change the lives of real women with cancer.
I'm just very, very, very grateful that they're doing this kind of research and that we have the opportunity, and I have the opportunity to benefit from it.
Stanford has always been a leader in terms of basic sciences and genetics back even decades ago. It's been a real privilege to work to begin to translate those discoveries into things that really actually help our patients.
This is a very exciting time in the world of cancer, and even more exciting here at the Stanford Women's Cancer Center. Just in the last year, we've seen some of the biggest advances that I have seen in my whole career.
We have learned over the last few years that a number of patients have genetic predispositions to develop ovarian cancer.
I go in for my first appointment with Dr. Dorigo, and one of the first things he said is, we need to get you tested for the BRCA1 mutation.
All the cells in our body, and in particular cancer cells, constantly go through the process of repairing DNA damage. A cancer cell, and particularly ovarian cancer cells, have the inherent inability to repair this DNA. PARP inhibitors are drugs that take advantage of the inability of a cancer cell to repair its own DNA damage. That inability is particularly high in those patients that have mutations in certain genes, in particular BRCA1 and BRCA2.
I think one of the things that made me laugh and made me realize what a good thing the PARP inhibitors were was when Dr. Dorigo sort of shook his head and he goes, well, if my mom was where you are, I'd suggest you go on it. Okay, that's the thing to do.
I just feel so lucky to still be here. And usually ovarian cancer, before all these new drugs got developed, it's not something that you can survive.
I feel incredibly blessed, actually, to be alive at this point. I know Stanford's been doing so much in ovarian cancer, and it gives me great hope that other discoveries are going to come along.
For many years, we've known that there are families out there that have something because we can see the cancer coming through the family, but we weren't able to determine what it was. It wasn't BRCA1 and 2. Starting in 2013, there was a big change of technology for us that allowed us to be able to test more genes at once.
My dad had stomach cancer. His mom had breast cancer. Her dad had stomach cancer, and his dad had stomach cancer. I was quite surprised to learn that there was a gene that causes lobular breast cancer and stomach cancer.
Christine was found to have a CDH1 gene mutation. It's also called ecadherin. This is a condition that causes something known as diffuse gastric cancer, which is a pretty serious type of stomach cancer. It also creates a risk for lobular breast cancer in women.
I remember the conversation with the genetic counselor, and I said, oh my gosh, I'm relieved. Now I know. Now I know. And then the next day, I read the report a little more closely, and I lost my mind.
Diffuse gastric cancer is a serious cancer, and when identified, it's often identified when it's symptomatic, which usually means it's at a much later stage and gets much harder to cure. One of the most dramatic genes we deal with is this one, because the intervention that we recommend is we seriously discuss with the patient the option of removing their stomach prophylactically.
It's a scary path. to consider having your stomach removed. But I think it's even scarier to die from gastric cancer. If I didn't have the knowledge, and if I hadn't had the surgery, very soon I would become ill. And the kind of cancer that this is, I believe there's a 4% chance of survival. So the big idea is life.
Genetically targeted therapies, genetic testing, options for prevention and screening are incredibly powerful. To see a family where a woman might say, you know, every woman in my family has died young of breast cancer, and to know that because of a genetic test result, we have the power to intervene. We have the power to find it earlier when we can cure it. We have the power to offer prevention strategies. That is incredibly hopeful and very exciting. And I think we really are making that kind of progress.
There have been two great advances, I would say, in the last 10, 15 years in all of oncology. One is genomics and gene-based therapies, and the other has been immunotherapy. And those two are coming together. Immunotherapy is based on a really simple idea. The body has defenses against human cancers, but those defenses are frequently subverted by the cancers themselves. The cancers frequently send out signals to the immune system that basically say, don't bother me, I'm a friend, you can go away, no problem. And the body's immune cells, what are called T cells, won't attack the cancer, even though normally their process is to do so. One of the great and exciting things that's occurred in recent years has been the realization that if we block this signal, if the cancer cell is no longer capable of telling the immune cell to go away, what will now happen is that the body's immune system will wake up, be activated, and attack the cancer cell.
I think I've been on 5 chemos. I was nauseated a lot. I lost my hair some. It's really kind of scary to be out of options. After I had been on all the chemos, my doctor in San Jose said I should go to Stanford to see what they have.
One of the questions that researchers have had for a fairly long time is, why does a particular type of body cell called a macrophage eat other cells? What macrophages do is they go around and they find damaged cells and they eat them. But how does a macrophage actually identify which cells to eat and which cells not to eat? It turns out that there's a protein on many normal cells called CD47. CD47 is what we think of as a don't eat me signal for macrophages. Here's the problem. Cancer cells are smart, and they frequently will undergo mutations. Those mutations will put this protein on the surface, and what happens then? The macrophage doesn't eat the cell. So researchers here at Stanford developed antibodies to this CD47, and you coat a cancer cell that's got CD47 with this antibody, and all of a sudden the macrophage wakes up and says, oh my gosh, there's a cancer cell here, I should eat it.
With the CD47, my tumor shrunk a lot. People usually don't live this long after being diagnosed. I'm sure it's not easy, even though you're smart, to figure out how to defeat cancer. I really appreciate all the work everybody's done for someone else.
I've always thought it was important to be hopeful about everything that's gone awry. And that's always worked for me.
Beverly is a fascinating story that tells you exactly where we've been and where we're going. Where we've been in the past is frequently using cytotoxic therapies, chemotherapy drugs that have lots of side effects, and Beverly got them all. And she was, in fact, I think all of us thought, close to dying as a result of the progression of her disease.
The first drug started August 9th, 2016. And I know everybody was ready for me to check out before that, because they even prescribed a whole bunch of morphine pills
And I said, "What for?" I didn't feel that badly.
As kind of a last hope, we actually started to look at her genomics, to look at the genes that could make up her cancer. And when we did that, we found something absolutely fascinating. Her tumor had something called microsatellite instability. This is a very jargony term that for practical purposes means that her cancer had lots of mutations. Patients who have microsatellite instability may have thousands of mutations that are driving their cancer. And Beverly's was one of these. These thousands of mutations actually turn the cancer cell into a really juicy target for the immune system if you just help the immune system out a little bit by giving one of the new checkpoint inhibitor drugs. About 10 days, 2 weeks after we started the therapy, I got a phone call from Beverly's significant other. He said, "Dr. Sledge, that mass that was on her chest wall, it's vanishing. Is that a good thing?"
I was, of course, happy. I think the doctors were more overjoyed than I was because they'd probably seen so much failure.
This is a patient where research, rapidly taken to the clinic, has deeply impacted the life of a patient who otherwise might have died.
I was always the person that did everything, planned everything in my family, the go-getter, the PTA mom, involved in everything.
The women who go on to clinical trials are my personal heroes. First, they're giving something back to their community and to their children. They're receiving a drug that frequently has not been given to many other people before. If you're a doctor who's involved in research, the patient is literally putting her life into your hands with this new agent. The amount of courage that takes, I think, is astounding.
The trial consists of an immunotherapy vaccine, Survivic, low-dose Cytoxin, and a trial drug called epacadostat. It's jump-starting and revving up your immune system to fight the cancer. And that's what interests me, is using my own body to fight this.
My hope is that I have a clinical trial to offer every patient, because we really believe that clinical trials are really the best way to receive treatment. There's that potential to gain benefit, having a lower chance of recurrence, a better quality of life, fewer toxicities depending on the nature of the study.
When I started seeing the reduction of my cancer by, I believe it was a little more than 30%, I knew this treatment was working, I was feeling better, and it gave me hope that I could possibly beat this and help others with treatments for themselves down the road.
Something I've heard over and over again from my patients over the years who go onto the study is, "I don't know if this will help me, but maybe it will help other people with cancer. Maybe it will help my children." That is something special when you think about it. That is courage beyond belief and bravery to behold.
It's very important that the research keep going for these newer treatments. I know it's years in the making before something does come, to the forefront and become a clinical trial. So I'm sure it's very exciting for these scientists and researchers to see their work becoming effective for patients like myself, that it's helping them with their cancer and their quality of life and having a new lease on life.
We have given patients back more time with their families. We have given patients quality of life. And with the new therapies, the tolerability is better. It is different from chemotherapy. And for me personally, it is extremely satisfying.
It's an amazing time to be alive, that you can do this kind of research and save this kind of lives. It just astounds me, and I'm extremely grateful.
I feel good. I'm active. I've returned to work. I work full time. I've gone back to the gym. Because of the research, and because of support to the hospital, it's directly reflected in positive patient outcomes.
I know why I come to work every day. I know why my colleagues come to work every day. We come in part to treat the patients that we have, because those lives have value and those are people we love and care about. But we also come for their daughters. We come with the idea that what we do matters not just because we're treating the patient in the room with us, but because we're trying to prevent that patient's daughter from having problems with the same disease a decade or 2 or 3 from now. And that, I think, for all of us is part of the excitement, the idea that the future belongs not to cancer, but to our patients. It's a great time to be a cancer researcher. It's a great time to be a cancer doctor. And I think ultimately that means it's going to be an ever better time to be a cancer patient.